Sir, before we commence the live session, I would like to request your cooperation for a quality assurance process, sir. It is imperative that the framing of doctors' videos meets our quality standards, and therefore I kindly request you to maintain a stable position and ensure proper camera framing throughout the entire session, sir. Additionally, please refrain from engaging in any other activities while the recording is live, sir.
Okay.
Furthermore, yes, sir. Furthermore, in the event of low network bandwidth, I recommend you sharing your presentation from your laptop. And for verbal communication, kindly join the session using a mobile phone, sir. Is that okay?
Yeah.
Okay. So, sir, we'll go live at sharp 6.
Okay.
So, greetings and a warm welcome to everyone. I am Sushri, the assigned moderator from Clarnet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform Clarnet. It stands as one of the largest live digital CME platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker. Dr. Krishna K Chaitanya is a consultant in critical care medicine at Sindhu Hospital, Hyderabad. With over 14 years of experience, he holds an MBBS, MD in anesthesiology, and DRNB in critical care medicine. He specializes in managing critically ill patients and is known for his expertise in inter, inter, intensive care and general anesthesia. And today, sir, will be talking on the topic application of Lung USG in critical care. I would like to take this opportunity to provide a brief overview of today's topic. Lung ultrasound is a vital non invasive tool in critical care, offering rapid bedside diagnosis of respiratory conditions more accurate than chest x ray and radiation free. It's especially valuable in ventilated patients for assessing lung recruitment, fluid status, and wearing readiness. Without any further delay, sir, I would like to hand over the session to you. Kindly proceed with your talk. Over to you.
Okay. Thank you. Yeah. Thank you, Clarinet, and thank you for the introduction. My topic today is about applications of lung ultrasound in critical care. The topic is vast and needs a thorough workshop, needs a hands-on training for proper application at the bedside, and it's a part and parcel of daily intensive care rounds. I am Dr. Krishna Chaitanya and a consultant critical care working in Hyderabad. My topic will go in the following slides. Introduction to basic lung ultrasound, basics, skills needed, artifacts needed for lung ultrasonography, probes and settings needed, basic science and correlation to the diseases found in the lungs, protocols, lung ultrasound scoring, diaphragm evaluation, and basic evidence along with the references. During the last 5 decades, lung ultrasound has developed into a core competence of intensive care medicine. It has become a part of daily examination of physicians working in intensive care, sub-intensive care, even in general medical wards. The ease of access to handheld ultrasound machines in wards where they were not available in the past facilitated the widespread use of ultrasound. Moreover, ultrasound was considered as unhelpful in the past due to intrinsic impossibility of ultrasound to penetrate the air, but we are using those imperfections for our diagnosis, for our treatment of the patients. In fact, most of the artifacts generated by the air tissue interfaces are needed for basic lung ultrasound examination, and always keep in mind they should not be erased by the advanced software. This needs a high diagnostic accuracy. It has been found for diagnosing various conditions like pneumothorax, edema, pneumonia, and pleural effusion, and lot more. In a critical care medicine field, it has demonstrated better diagnostic sensitivity, better than a chest X-ray. The point of care approach has a lot of benefits, like it is fast, it is real time, it is dynamic, it is cost effective, and moreover, LRA principle as low as radiation less possible, and it is considered to be a non-invasive diagnostic evaluation with extremely high feasibility and patient safety as exposure to ionizing radiation or contrast dye is avoided. Lung ultrasonography is particularly suitable for patients at risk like critically ill children, even pregnant women. A four-step definition of what lung ultrasound skills are needed. This is a four-step: basic, intermediate, advanced, and expert level. An international study has standardized lung ultrasound training and conducted in 10 ICUs found among resident and staff working in ICUs, anesthesiology services, emergency medicine, and internal medicine wards. They have concluded that 25 transthoracic ultrasound examinations supervised by an expert provide the basic skills. The basic skills we will discuss, most likely the basic skills. The intermediate basic skills, A lines, B lines, and consultation are enough. Intermediate requires movements of the pleura, finding out the quantification of the effusion, various diagnostic dilemmas, advanced computation of lung ultrasound score, clinical management of acute respiratory failure, guidance of mechanical ventilation strategy in expert level. Okay. Coming to basic probes, depending on the clinical question that needs to be answered, high frequency probes, 5 to 12 megahertz, which have lesser penetration, have better definition for superficial tissues. For example, like pleural movements and artifacts generating from pleural lines. Whereas low frequency probes, better visualization of deeper findings, consolidation efficiency may be useful even for the most likely for the lung basis. So the probe use depends on the even the body habitus of the patient. Settings, the depth has to be adjusted according to the anatomical characteristics of the patients. Obese patients the depth may vary. The lung region to be examined, anterior parts, linear probe or superficial penetration is enough. Usually 68 centimeter is needed. This is a usual guideline, but posterior fields may need a required deeper setting. Individualized depth settings are preferred. Probe orientation, longitudinal. Here there is an upper rib, lower rib. This is the probe. It forms a bat wing sign. We will discuss later. This is a transverse. In between the ribs, you try to align the probe. This is a game of artifacts. Whatever we learn about lung ultrasound is a game of artifacts. We try to interpret the artifacts produced. Previously, ultrasound was considered is not useful for lung ultrasound. In around five editions, previous about 5 editions back, Harrison have mentioned clearly that lung ultrasound is not useful for diagnosing lung diseases. But now, recent editions, last 3 4 editions, they have modified because we are playing with the artifacts. These artifacts are generated by high difference in the acoustic impedance of the subcutaneous tissue above the pleura and air beneath them. They can be visualized in a bidimensional images with a B mode. Additionally, M mode can also be used for motion. This is considered as a lung zones. We try to divide the lung into zones. This is anterior axillary line. This is posterior axillary line. This is superior zone, inferior zone. Superior zone, inferior zone. This is posterior superior zone, posterior inferior zone. So there comes 6 zones on each side. 1, 2, 3, 4, 5, 6. Anterior superior, anterior inferior, lateral superior, lateral inferior, posterior superior, posterior inferior. So each side 6 comes down 12 zones. This needs a comprehensive evaluation of lung where you need to calculate lung ultrasound scores and others. Whereas focal evaluation to rule out pneumothorax, to find out focused decisions like quantification of effusions, these are all focused examination through lung ultrasound. These are A lines. We are playing with the A lines artifacts. This is an A line reverberation artifacts. See, there is another A line. There is another line, A line. This is a rib casting a dark shadow behind. This is a rib casting a dark shadow behind. This is the pleura. So this is considered to be a bat wing sign. These are wings. Wings are due to ribs. This is the body of the bat. Coming to basics, again a repetition. This is a pleura line. These are reverberation artifacts. These are all A lines. Whereas B lines, this is a pleura. These vertical lines coming from the pleura are considered to be as B lines. They may vary in thickness. They may vary in number. Sometimes they lot of them together fuse. So we will come together the difference between A lines and a B line. A line is a horizontal line, parallel. This is always parallel. The most important thing is they always erase parallel to it. They are always equidistant. But B lines, these are vertical lines, also called as comet tail artifacts. They are perpendicular to pleural surface. They arise from pleural lines. Okay, they always arise from pleural lines and but erase A lines. If there are B lines, they will not be A lines. So there is a sentence called they arise from pleural lines but erase A lines. So efface or erase. At least three, more than three is considered to be significant. Even that depends on the probe we use. Someone say linear probe, more than seven are needed to be pathological. For a deeper probe, uh, around more than three is considered to be pathological. Coming to basic lung sliding, this is pleura moves along with the ventilation. Parietal visceral pleura always move aligning together when there is a regional ventilation. But sometimes these lung sliding, there may not be pleural movement. What pleural movement we consider is a bag of ants marching in a line. There is no ants marching in a line. This is called absence of lung sliding. Seashore sign is straight lines above pleural line, sandy pattern, pleural line visualized in M mode pattern. This is a normal. Horizontal lines above and below pleural line considered to be an absence of pleural movement is the stratosphere sign. Okay, here there is an abolished barcode like sign, abolishment of pleural movement. Coming to lung, this is the lung sliding is absent again. There is a movement of pleural lines synchronous to cardiac rhythm. This is called a lung pulse, where heartbeats are always visible along with the breaths. It indicates pleural touch, but the regional ventilation is impaired, like an endobronchial ventilation intubation or selective intubation, like endobronchial intubation. Early phases of atelectasis, pulmonary contusion, regional hyperinflation, or even emphysematous bulla. A lung point is a contact point between a collapsed lung and a pneumothorax air collection. Lung point is considered to be the diagnostic of a pneumothorax. A repetition, if lung sliding is absent, lung pulse is visualized, a pneumothorax is ruled out with a 100% negative predictive value. As long as there is no complete collapse of the lung, the presence of lung point increases specificity for detection of pneumothorax to nearly 100%. In the absence of sliding and lung pulse, pneumothorax has to be suspected, but you cannot rule out. The visualization of lung point has a specificity of 100%. When in doubt, move the probe to the lateral areas of thorax. You can find the lung point. Lung ultrasound signs based visualized in a consolidation or pneumonia, shred sign where this is a pleura. There are subpleural consolidation, subpleural echoporia which is delimited by irregular borders, along with the juxtapleural submolar consolidation. In later stages, there will be hepatization where tissue-like patterns similar to liver may appear. Air bronchograms are intraparenchymal hyperechoic images you see here. Sometimes they may be static, sometimes they may be dynamic. Static present in atelectasis like conditions, dynamic in a pneumonia like condition. Coming to pleural effusion, this is a hypoechoic space. This is a hypoechoic space due to pleural effusion. A hypoechoic or anechoic space between pleura usually visualized in the dependent area because water gravitates down. So usually pleural effusion gravitates down unless it is very severe. Similarly, pneumothorax air ascends up against gravity. So we start from the anterior chest wall to rule out to find out the pneumothorax. So always air ascends up, water moves down. Air always examine from the anterior chest wall. Pleural effusion try to examine from the posterior lower parts. The echogenicity to an extent helps in diagnosis whether it is a transidative. Transidative is homogeneously echogenic, whereas in exogenic there may be strands, septation, sometimes multiloculations. In M mode, you can see a sinusoidal sign. This is a lung floating in the fluid. Sometimes some studies say that around 15 to 20 ml is enough. Some studies so even small 5 ml can be you can detect with an ultrasound, whereas minimum 150 ml is needed for the detection of pleural effusion in an X-ray. Quantification, Balik's formula, there are three formulas, Balik's formulas, Ebenberger's formula, and others. Balik's formula, the other formula needs an erect patient, but Balik's and Ebenberger, where critical ill patients may not be erect, may not be standing, you can use Balik's formula or Ebenberger's formula, where patient can be supine with mild trunk elevation, transducer perpendicular to the chest wall, and measure distance into 20. Measure distance into 20. The measured distance is between parietal and visceral pleura, and it will be in mm. Ivanberg's formula, transducer will be perpendicular. The distance between lung and chest wall will be measured. This is the formula. The problem is if the distance between floor layers is very small, less than 18 mm for thin efficiency, Balik formula is used rather than Ibenberger's formula. Coming to lung aeration score, lung ultrasound scoring, coming to we approach from zero left to right. Okay, zero is normal pattern, normal A pattern. B1 is B lines are there. Okay, moderate loss of aeration with three, at least three. These are B lines, vertical lines. At least three or more. Less than three B lines is considered to be a normal. This is a normal aeration. At least three or more B lines on ultrasound is considered to be score 1 or less than 50%. This see the triangle like shape here. Less than 50% of subpleural consolidation comes under score 1. Whereas severe loss of aeration, B lines becoming fused, called coalescent B lines, with subpleural consolidation occupying more than 50%. This is considered by score 2. Score 3, there is a complete loss of aeration with a consolidation tissue-like appearance. Coming to basic diagnosis, we'll try to apply all these signs for diagnosing various diseases. Okay, the approach remains other than protocol. These are all basic charts you can keep at the bedside in your pockets. Take a printout and try to apply whenever you try to do an ultrasound of lungs. A lines, whether A lines are present or B lines are present. A lines, scan the anterior scanning, always scanning from the anterior zones. Is the lung sliding present? If the lung sliding is not present, scan the posterior lateral zones. If you are able to see a lung point, it is a pneumothorax. See, this is a lung point. There is a sliding one, there is a non-sliding pleura. This is a lung point. It is a diagnostic of pneumothorax. If you're not able to see the lung point, you have to find out the lung pulse. If there is a lung pulse, it indicates just we have already discussed a local regional ventilation impairment. Okay, like endobronchial intubation, early phase of atelectasis, even asthma COPD, hyperinflation, mechanical ventilation patients, even emphysematous bullae. If the lung sliding is present, A lines are present, it is a normal lung. Then you need to find out a subpleural consolidation present or not. Coming to B lines considered to be focal, diffuse with thin regular pleura, diffuse with thick irregular pleura, or we will come into diagnosis. Focal, find out subpleural consolidation is there. Add other techniques like echo to rule out a pulmonary embolism to find out a DVT, a subpleural consolidation, that to focal always rule out a pulmonary thromboembolism. Okay. Coming to focal, other consolidations, subpleural consolidation, along with other consolidation, focal consolidations are present, that too unilateral, find out, rule out a pneumonia. Diffuse with regular pleura, there is no irregularity. It may be effusion and along with effusion and consolidation, most likely cardiac origin. If it is diffuse B lines with thick irregular pleura, if there are consolidation, that to both sides, it is an ARDS. It may be always, it can also be an interstitial lung disease. This is another approach, another flowchart where you try to apply recruitment maneuver or a proning maneuver, proning or PEEP, both are recruitment maneuvers. You try to apply basic lung ultrasound at the bedside. If the anterior areas are spared with severe loss of aeration in the posterior, with lung ultrasound score less than 2, focal distribution prone, because of regional difference in the damage of the lungs. If the severe compromise of all pulmonary areas, there is no both anterior and posterior, with the lung ultrasound score anterior more than 2, posterior ultrasound score more than the anterior lung ultrasound score, and even it is non-focal distribution, you can try a PEEP trial. PEEP to an extent can help in improving the hypoxemia. Coming to patient already on ventilator patient, and you are suspecting a VAP, ventilator associated pneumonia, entity found after 48 hours, infection found after 48 hours. Static air bronchogram, if it is a static air bronchogram, find out obstructive atelectasis, disobstructive fiber optic bronchoscopy. Dynamic air bronchogram or arborescent, some studies have found arborescent or tree-like air bronchogram, try to rule out a VAP, perform a ball. See, some studies found that tree-like pattern VAP. They have also found that ultrasound is far better than a clinical pulmonary infection scoring. Another flowchart, Always try to apply these three to hardly 3 to 4 charts are there. Try to apply all these things at the bedside to make a meaningful conclusion of hypoxemia or meaningful dissection of differential diagnosis of various lung diseases. Always clinical evaluation before lung ultrasound. Clinical evaluation is the core before proceeding to the lung ultrasound or before holding a probe. Lung ultrasound, this is already discussed. Lung sliding present or absent. Lung point present, pneumothorax. Absence of lung sliding with lung point, pneumothorax. Absence of lung sliding with lung pulse. There may be atelectasis along with other causes. Anechoic areas, sinusoidal sign or mode, pleural effusion. Tissue-like pattern, shed sign, dynamic air bronchogram, pneumonia. Only tissue-like pattern, passive atelectasis. B profile, alveolar interstitial syndrome. Alveolar interstitial. Whatever B profile, it is more likely an interlobular septal pathology. If more, even alveolar may be involved. So interstitial can be affected by a blood by a water, any fluid, even fibrosis. So B lines can be seen with any of the pathologies. Focal, multifocal, homogeneous, bilateral. If it is homogeneous, bilateral, homogeneous means the pleural line is thin, regular. Whereas multifocal, heterogeneous, pleural line is not thin, thick. Okay, bilateral, there may be associated with consolidation in ARDS. If there is a subpleural consolidation, try to rule out a pulmonary embolism because subpleural consolidation may also be present in a pulmonary infarct. Again, a lung ultrasound score repetition. Why there is a even it helps in not only lung ultrasound, not only helps in quantification of the loss of aeration, it also helps in if the score is less than 13 at the end of SBT. SBT is spontaneous breathing trial. It is a predictor of an extubation success on a study based on a study. More than 17, high chance of post extubation distress and extubation failure. 13 to 70, more intermediate risk. So it indicates a high probability if the score is more than 17, there is a high probability of post extubation needed for respiratory support. This is a blue protocol. Blue protocol is the essence of a lung ultrasound devised by Liechtenstein. There are 6 clinical conditions. We will come by step. These are called blue points. These circles, these bullet-like targets are called circles. You try to hold your palm below the clavicle anteriorly. Try to overlap the second palm over the first palm. Okay, the midpoint is called upper blue point. The midpoint of the second palm is called as a second blue point. You try to from second blue point to come posteriorly to the posterior axillary line. This is called as a PLAPS point. PLAPS point is a posterior lateral alveolar pleural syndrome. PLAPS, PLAPS, posterior lateral alveolar pleural syndrome. This has this single chart to an extent can rule out many diseases. See, this is a plug point. Some say 9 to 10th space posterior axillary line. Okay. If there is a lung sliding present, B profile is present, pulmonary edema. If lung sliding is present, but there is A profile, rule out pulmonary embolism. If there is a thrombosed vein. If the veins are not thrombosed, then you go to the PLAPS point. This is the PLAPS point where the midpoint of the lower blue point goes posteriorly to the posterior axillary line junction. PLAPS point, if there is PLAPS point pathology, it is a pneumonia. There is no PLAPS pathology, it can be asthma or COPD. This is considered as a nude profile. Okay. Coming to lung sliding is absent, B profile is present, it is called pneumonia. This is called B dash profile, B dash, A dash. Why dash? Because lung sliding is absent. Coming to A dash profile, if it is there is a lung point, it is a 100% specificity of pneumothorax. If there is no lung point, rule out other diagnostic modalities as already discussed. AB profile, this is in between. One on one side it is A profile, other side is B profile called C profile. Then it is you have to rule out a pneumonia. This is a basic blue protocol. Another protocol is a false protocol where fluid administration limited by lung ultrasound. We try to rule out obstructive shock, then a cardiogenic shock, then initial A lines after fluid resuscitation in a septic shock. Initial A lines may become turned into B lines. This is a false protocol. Okay. This is basic approach, whether it is a acute cardiogenic pulmonary, chronic heart failure, ALA or ARDS. ALA terminology is not there now. Pulmonary fibrosis. Based on clinical setting, all these have B lines. B lines distribution is important because multiple diffuse bilateral with a pulmonary edema. Multiple diffuse bilateral following decubitant regions, black and white lung, chronic heart failure. In a cardiogenic conditions, there may be associated effusions and echo may be abnormal. In ARDS is an acute, billions are present. These are always non-homogeneous with the presence of spared areas. Associated consolidation may appear, as already discussed, associated effusions may occur, other pleural alterations may be present. In a pulmonary fibrosis, in an ILD-like condition, chronic conditions, billions may be present or not. They are most likely in the posterior at lung base. Pleural thickening is present, echo can be normal. But in ARDS, echo can be normal. Coming to diaphragm, lung ultrasound is not complete according to recent international guidelines of lung ultrasound. They have incorporated diaphragm evaluation also in lung ultrasound evaluation in critical care medicine. Okay. Coming to diaphragm excursion, you try to use a 3.5 to 5 megahertz phased arrow probe below right costal margin or left costal margin in the mid-clavicular line. We will come to know here. This is the convex transducer, or you can use phased transducer below right subcostal margin, mid-clavicular line. In M mode, diaphragm excursion can be seen in centimeter, speed of contraction in centimeter by second, in inspiratory time, you can see duration of the total cycle can be measured. The thickening and thickening fraction can be examined by a linear probe in an M mode. How? This is the zone of opposition, linear transducer, where between anterior axillary line, posterior axillary line, between 9th and 10th intercostal space, you try from below, above, try to trace from above, below, there will be a zone of opposition. See, this is the chest wall, this is the diaphragm, this is the pleura, this is the peritoneal lining, this is the zone of opposition. This we see in a linear transducer in the lateral part. Okay, this we see in the mid-clavicular line, right subcostal region. This is the seen in the linear transducer lateral part. When we try to apply M mode, there will be an excursion of the diaphragm. These are diaphragmatic excursion. These peaks and troughs, these are all excursions. As the diaphragm contracts in a quiet breathing, this is the deep breathing where the peak is higher. Okay, this is during voluntary sniffing. These are all diaphragm ultrasound. Diaphragm dysfunction can be diagnosed. What is thickening fraction? Inspiratory thickness minus expiratory thickness by expiratory thickness. It is a thickening fraction formula. Total we multiply into 100. Diaphragm dysfunction is an entity where diaphragm, some of the muscle fibers may be affected by molecular level. Sometimes the fibers may die in the course when the patients are on the ventilator. It has been found that the diaphragm dysfunction occurs even on the first day of the mechanical ventilation. So diaphragm dysfunction can be diagnosed usually by an excursion depth less than 10 mm. And this is associated with an adverse outcomes where there is a prolonged duration of ventilation, prolonged ICU stay. Diaphragm thickening fraction can be used as a predictor for weaning failure. The thickening fraction formula is inspiratory thickness minus expiratory thickness by expiratory thickness into 100. It has been found a comparable accuracy to RSBI, Rapid Shallow Breathing Index. This we have already discussed. Convex probe below right subcostal region, mid-clavicular region, costal region, either right or left. Linear transducer between anterior and posterior axillary line, you try zone of opposition. This is the basic diaphragm. This is the M mode excursion. This is M mode on the lateral opposition. This is the peritoneal lining. This hypoechoic region is the diaphragm. This is the pleura. Again a repetition. This is the diaphragm. This is the diaphragmatic excursion. Okay. Measuring, we try to keep on measuring all these things. The settings, you can find out the time of inspiration. Thickening, we can calculate by measuring the distance. Thickening fraction, you have to apply the formula. What is the clinical implications of diaphragm ultrasound? Critical ill patient with respiratory failure or mechanical ventilation. DD is diaphragm dysfunction. To diagnose diaphragmatic dysfunction, diaphragmatic excursion is less than 1 centimeter. Thickening fraction less than 20 to 25%. Less than 1% associated with high mortality rate in patients with acute respiratory failure. Weaning outcome will be lesser. Thickness fraction less than 29% associated with prolonged ICU stay, prolonged mechanical ventilation, and increased mortality. To find out the atrophy of diaphragm, diaphragmatic thickening and expiration decreases each day 6 to 7% during mechanical ventilation, especially on controlled mechanical ventilation. This is more than 10% lower in 44% and unchanged in 44%. The atrophy, more than 10% decrease associated with increased ventilation period, increased ICU admission, increased risk of complications. Sometimes there is an entity called diaphragmatic hypertrophy, where diaphragmatic thickness in expression increase more than 10%. There is an increase. This is also associated with increased duration of mechanical ventilation. For predicting weaning from mechanical ventilation, diaphragmatic excursion, other studies less than 1 to 1.4 centimeter, thickness fraction less than 20 to 30%, some take less than 15%. So diaphragmatic ultrasound weaning prediction associated with increased weaning failure. So this is a crisp and gist of what are applications of various applications of lung ultrasound in critical care. Okay, a hands-on training, basic blue protocol and various flow charts, basic identification of A lines, basic identification of B lines, trying to find out the effusion in the posterior part, respecting the gravity rule, respecting the artifacts. Always identify the artifacts, A lines, B lines. B lines always erase from pleura, emanate down, erase B lines, come down to the screen. Sometimes jet lines are present, they do not arise from these are also artifacts, they are not clinical significant, but they do not arise from pleura, but may come down to the screen. Sometimes they may stop in between. There is an artifact E lines where they do not arise from pleura, they arise above the pleura. These are seen in subcutaneous emphysema and other countries. These are all artifacts. So always identify, have a basic idea of artifacts. Always respect the gravity rules. Air always ascends. Try to find out pneumothorax from the anterior and go laterally posterior. Always respect the gravity rule. Air ascends, fluid always goes to the dependent portions. Pleural effusion, try to quantify from posterior to anterior. Even it also helps in ultrasound for procedural like pleural aspiration, pleural fluid aspiration, even pigtail insertion and others. Basic approach to hypoxemia, ruling out pneumothorax, finding out the consolidation, differential diagnosis of a consolidation finding like static air bronchogram, dynamic air bronchogram, trying to narrow the differentials, the cause of consolidation, trying to take the whole clinical picture rather than basic probe is essential. Subpleural consultation is important to try to rule out an infarct, find out the various differential diagnosis. Always try to compare the other side. In a comprehensive examination, you can try lung aeration score. In a weaning, you can also do a comprehensive by lung aeration score. Always do on both sides, both superior and inferior, anterior and posterior. Respect the anatomy. Try to dissect the differential diagnosis by bedside pocket charts or flow charts. Apply a blue protocol. I think lung ultrasound is the easiest ultrasound you can learn, and it has a very easy learning curve. These are all my references. Thank you. Thank you. I'm done.
Yes, sir, just
Thank you so much, sir. The content was highly informative, sir. So, sir, we have received a few questions from the participating doctors. Hello.
Tell me.
Yes, sir. Sir, for that you need to on your video, sir.
Yeah, okay.
Okay, sir.
Yeah.
Sir, I hope my screen is visible to you. Hello.
Yeah, yeah,
Okay,
tell me.
sir.
Yeah. Should I proceed answering?
Yes, sir. Please.
Yeah. Yeah, critical ill patients. Critical ill patients are a tough job. Okay, single decision making is single modality of choice. Decision making in a critical ill patients, treating the patient as a whole is a difficult task. Coming to the question, diagnosing pneumothorax in critical ill patients, ultrasound compared to chest X-ray CT. They have studies have shown that ultrasound is far better than a chest X-ray. But coming to CT helps to an extent for diagnosing pneumothorax, but depending on the clinical condition of the patient, whether the patient can be transported or not, depending on the skill of the operator who has learned the ultrasound, who has better skills, can to an extent help in diagnosing the lung point. Okay, lung ultrasound purely depends on the operator skills. So compared to chest X-ray, it is far better. Coming to CT, for critical ill patients who are not able to be transported, lung ultrasound to an extent helps far better in such patients. Okay. Yeah, serial lung ultrasound findings in fluid management in septic shock. We have already discussed it. There is a false protocol, fluid administration of lung in lungs limited sonography, false protocol, fluid administration, lung limited sonography, where whenever a patient comes, you're not sure whether what kind of shock the patient is in. We always try to rule out a more dangerous types of shock, like obstructive shock. First, rule out the obstructive shock by finding out the some pneumothorax or a cardiac tamponade or anything. Then find out the cardiogenic shock, where you find out there is a severe LV dysfunction or regional wall motion abnormality or some kind. Then find out whether it is a hypovolemic shock. In a hypovolemic shock, the patient initially has halines. If you give a fluids, they will recover, the BP may be recover. But in a septic shock patients where there is a high vasodilatation with increased permeability, high chances of permeability, initial A lines after giving fluids may be converted into the B lines. So false protocol to an extent helps in guiding fluid management in a septic shock. This always take in a critical ill patient, always take the composite picture, the clinical picture, the background, clinical examination, and serial ultrasounds aid are just like a tools. They aid in a your management rather than solely depending on them. Okay, next one. Ultrasound in weaning, we have already discussed weaning lung aeration zone, lung ultrasound score, where we try to quantify the aeration of the lungs. We have applied in COVID also. We divide lungs both sides, lung into zones. Okay, the total score comes to from 0 to 36. Okay, 1, 2, 3, 4, 5, 6. Okay, on the each side, upper, lower, superior, inferior, anterior, lateral, superior, inferior, posterior, superior, inferior, both sides, total 12 zones, 0 to 3, 12 into 3, 36, 0 to 36 scores. Okay, in more than 17 score, if the lung aeration, I will show you the slides, if the less than 30%, 13 lung ultrasound score, predict, some studies have shown they have been successfully weaned. Always rule out the other causes of difficulty in weaning. With more than 17, the chances of post-extubation respiratory distress are high. Always try to complement the diaphragm ultrasound along with the lung ultrasound. The international guidelines of ultrasound in lung have included the diaphragm ultrasound in the lung ultrasonography, and they have propagated the use of diaphragm in weaning. Try to use the thickening fraction, diaphragmatic excursion, and diaphragmatic thickness in expiration during weaning process. Next one. In what way does lung ultrasound improve the safety and success during thoracocensis of tube insertion? Okay, we the basic question would be is the answer is that we always respect the anatomy. We respect the patient, individual patient rather than the group of patients, because each individual is different, each individual's anatomy is different, each individual's history is different, each individual's surgical history may be different, each individual's anatomy may be completely different. Lung ultrasound for thoracocensis or a tube insertion. Tube insertion is basically an emergency tool. There is no need of an ultrasound for an emergency cases. But thoracocensis, even in some certain cases of tube insertion with a history of a cardiac surgery, thoracotomy or other surgeries, finding, respecting the anatomy, delineating the anatomy before putting a tube, before putting a pigtail is important. Next one. Lung ultrasound replaces chest X-ray for daily monitoring. It always depends on the operator experience, how safe as a critical care physician we are there. Lung ultrasound have shown, studies have shown they are far better than chest X-rays. They are less invasive. They respect Alara principle as low radiation as possible principle. They are cheap, they can be reproduced, they are dynamic, you can do as many times as possible, they are economically viable, they do not cause radiation trouble. So if in the hands of a proper skilled person, it helps, it can replace chest x-ray for daily monitoring. Next question. Okay, thank you.
So thank you so much for answering all the queries of the delegates.
Thank you.
And thank you so much, sir.